One of the ACEs Aware Ventura County virtual lecture series. This session is Motivational Interviewing and Introduction. Please, as you join, make sure you have registered via the SurveyMonkey link. And at the end of this session, you'll be reminded again to complete the evaluation. Everyone who does Everyone who does complete the registration via SurveyMonkey will be entered into a drawing for an ACEs Aware Ventura County prize. And while we continue to wait just another minute or so for people to hop on, we read this slide for a few reminders. And if you are seeking continuing education credit, just to remember to stay on for the entirety of the session and complete the evaluation at the end. We'll get started very shortly. Thank you.
All right, we'll go ahead and get started. Thank you so much for attending today. Our speaker is Dr. Joy Chudzynski. She'll be presenting on motivational interviewing and introduction. Dr. Joy is a clinical psychologist specializing in addiction treatment and trauma for individuals and couples. In addition, Dr. Chudzynski provides clinical trainings for mental health professionals on topics of substance use, trauma, and mental health assessment and treatment. She's an assistant clinical professor at UCLA's Center for Behavioral and Addiction Medicine in the Department of Family Medicine. There she provides short-term evidence-based treatments for a range of psychological and substance use disorders within a primary care setting. Dr. Chudzynski earned her doctorate in clinical psychology from Pepperdine University and completed a postdoctoral fellowship at Cedars-Sinai Medical Center, Department of Psychiatry and Behavioral Neurosciences, where she specialized in cognitive behavioral therapy and dialectical behavioral therapy. Her areas of expertise include substance use, trauma, motivational interviewing, the neurobiology of drug abuse, CBT and DBT interventions, and co-occurring disorders. After the lecture, Dr. Chudzynski will be responding to your questions. You're all encouraged to submit questions via the chat box for our speaker to answer during the Q&A session. And now I'll turn it over to our presentation.
Thank you so much for that great introduction. I appreciate it. So as you've heard, today we are going to talk about motivational interviewing, and this is going to be just a brief introduction because you'll have some more sessions on motivational interviewing down the line. And this is to kind of get you introduced to what it is and the main concepts that are important to know. So the learning objectives for today are you will be able to define what an adverse childhood experience is, their prevalence, their health disparities, and I know you're learning a lot about this in the other trainings that you're doing. Specifically to this presentation too, you'll be able to know what the spirit of motivational interviewing is. What is this when we talk about it? Name 2 types of change talk, and you'll also know what change talk is, because I'll tell you what that is. 2 ways to elicit change talk from parents and patients and caregivers, and maybe parents too. And then 1 way to manage resistance sometimes when that's coming up. The ACEs Aware mission: to change and save lives by helping providers understand the importance of screening for adverse childhood experiences and training providers to respond with trauma-informed care to mitigate the health impacts of toxic stress. Yes, and the good news is motivational interviewing pairs with this so perfectly, because a lot of times the patients and the caregivers and the people you see don't understand what's happening, don't know what ACEs is, don't know what an adverse childhood event is and how this relates. And these are the skills that MI can help with to help you bring them awareness into this and maybe treatment as well. 10 categories of the adverse childhood experiences. You can see here they reduce it into categories of abuse, neglect, and any household challenges, things that happen in a child's environment that as they're growing up can be difficult and cause toxic stress. And as you probably know, the more of these that one has, the higher ACEs score that they would have. Which brings us to talking about the stress response, because we know, especially after these last 18 months, we've all had stress. And there's a difference between positive, tolerable, and then toxic stress. So just briefly, you think about positive stress as something that's tough, that raises your heart rate, that you might get nervous about. You have that bodily activation, but you're able to get through it. And it doesn't really usually leave a lasting impact. Tolerable stress is just, as it sounds, something that happens that maybe you wouldn't have chosen to happen. So the immigration process, a natural disaster, something like that, but it's time limited. And because of buffering effects and interventions or adult caregivers being able to intervene, someone usually gets through it. It's tolerable. It doesn't last. And then we have the toxic stress, and that's really what we're talking about with the ACEs. And these are, just like the word toxic sounds, it just keeps going and it's not good for you. You can't necessarily get out of it. So that's abuse, neglect, the household challenges from the previous slide. And these are the things that we know that when they happen, when children are young, it literally changes the way their brains develop. And so this is why, in part, it causes these health and psychological concerns and issues later on down the line. And that's what we're trying to help with these trainings. So how does motivational interviewing, or MI, fit in with ACEs, the ACE screen? First of all, what is motivational interviewing? So probably many of you have heard of it, maybe even had training in it, maybe use it a lot, and awesome, that's great. And for those of you that don't, or don't know exactly how to use it, hopefully today you'll be able to get a handle on some specific things you can do. Really what it is, it's a style of talking with people about helping them reduce their health risks and changing their behavior. And you're really arranging conversations in a way so that the person, your patient, is talking about why they want to change, how they would change, why would it be important. They're talking themselves into it based on what they want, their values, their interests. And so our job as the helper, the physician, the nurse, the mental health provider, is to arrange that conversation so we're guiding them in that way. And that's what we'll talk about today. Hopefully by the end of today, you'll know how to do that. So what is motivational interviewing? It's a lot of things, but three of the main important things to always kind of be thinking about is it's collaborative. So we are working together with the patient. Oftentimes, our healthcare system has been set up so the physician, the nurse, the person who is the healthcare provider is sort of telling the patient what to do. And in some sense, we're still doing that, but we're trying to really be collaborative with the patient. So it's both of us working together against whatever this problem is or the issue is. And that's really a hallmark of motivational interviewing. The second part is it's patient-centered. And I know you hear about patient-centered care all the time, and you provide patient-centered care. And motivational interviewing really helps you to provide patient-centered care because we're literally trying to meet the patient where they're at and not judge where they're at. Really be able to be curious about, okay, how come you feel that way? What would that be like? You're really trying to see where they are. So that's the information that helps you learn how to guide them based on their values. And then the third part with motivational interviewing is there's always a specific objective. And sometimes this can get lost. But what that means is when you are working with someone, you're thinking in your mind, what am I trying to motivate them on? So when a patient comes in, what's my goal here? Do I want them to just come back in for another appointment? Am I going to try to get them to take medication because that would be important in their care? Do I want them to get a routine screening that they've put off for a couple of years? What are you trying to motivate on? Because that's going to help you guide your questions to them. The goals of motivational interviewing: enhance motivation and commitment for change. And so how we do that is we try to elicit change talk from the client. And I'll tell you all about change talk in a second. And by doing that, it helps the client move through the stages of change. We want to resolve ambivalence. When we're trying to make a decision, when we feel two ways about something, there's a lot of ambivalence. We just want to help guide the patient towards working that out and avoid eliciting or strengthening resistance. And this can happen a lot where we find ourselves maybe arguing or saying, well, but this would be really good for you. That's not motivational interviewing. We're trying to take another approach. And that's what we'll talk about today. So, change talk. You can think about it. There's lots of acronyms in motivational interviewing. And this one's darn cat, which totally works for me because I'm a dog person. Change talk is something that the patient or the caregiver engages in that indicates they are unhappy with the status quo or how things currently are. So, for instance, and change talk comes in different categories of desire, ability, reasons, need, darn, and then the cat part, commitment, activation, taking steps. So what this means is if I'm thinking about, let's say, stopping smoking cigarettes, and I say, I really wish I could stop smoking. That is me talking. I'm giving you change talk in the desire category. I really want that. And so if we're using motivational interviewing, want to start training ourselves to listen for what is the patient saying about how they don't like what's happening, because then we can get curious about that. So how change talk fits in to the stages of change. You probably learned about this in grad school or med school or a very long time ago, or maybe recently. But a lot of people don't think about necessarily how it can fit into their everyday work. If you take a look at pre-contemplation and contemplation there, 1 and 2, pre-contemplation is if someone's in pre-contemplation, they're not thinking about making a change. So for instance, a person comes in for care and you realize on a screen that they are drinking 6 beers a night, or they're using marijuana, but that's not what they came in for. So they're in pre-contemplation about even changing their substance use. It's not on the map. Well, what do you do there? Because you think it's important. That's where motivational interviewing comes in, because we can start to, if you see under there, primary task is to raise awareness and just really connect what you as the healthcare provider think is important. We should look at, just how much you're drinking or how much you're smoking and how that impacts your health. And you tie it to what they came in for. Maybe they're not sleeping, or they've gained weight, or they're having trouble breathing, something like that. Contemplation is they're thinking about the change, but there's a lot of ambivalence. They maybe don't know, do they really want to stop smoking? Do they not? It really helps with stress. I don't know. Back and forth. Do I really want to take my kid in to the doctor? I know they've got some problems, but it seems like a lot of work and I don't really trust the system. I don't know. And we see that a lot. The primary task there is helping to resolve that ambivalence and helping the patient choose moving towards change. And so these fit in with the change talk, because if you think about, okay, with this patient that comes in, where are they in the stages of change? Is it not even on the map? Are they kind of thinking about it? Are they in determination where they're like, no, I need to make this change. Let's do this. Okay, then we're going to help them identify, how do we do this? What will work? So it can kind of help you think about, well, what questions do I ask? How can I be curious to help move them on? And this is combining those last two slides. If you see down there at the bottom, pre-contemplation through action, and then in the triangle are the darn up on the left side and cat coming down the middle. Usually, when people are in pre-contemplation and contemplation, they're thinking about change. So that's where we have the darn part. They call it preparatory change talk. People are thinking about making a change. So they might talk about their desire, ability, reasons, or need to make a change. Desire, I really want to. Ability, well, I did it before. Reasons, I have to because I really want to lose weight, get my kids back. I can tell so-and-so's unhappy at school. And the need is like a more urgent reason usually. And then down on the right side, you have mobilizing change talk. And that's when the patient is saying, okay, I'm ready to do something. We don't just then switch into telling them what to do, but instead we use these same principles of motivational interviewing to work with them collaboratively and find out, well, how can we help them succeed? I love this slide because when we're thinking about making changes, there's often a lot of ambivalence. You know, you're feeling two ways about things. And remember, the change talk is what the patient is saying that they want to do, how they want it to be different, to make a change. Well, the other side of that is the sustain talk. And that's why do they want to keep things the way they are? And really, it's a balance. Because we will hear people say, I really want to stop smoking. It's just so hard, especially after I eat. I just have to have a cigarette. I can't. I haven't been able to cut it yet. Well, there's change talk in there. I really want to quit. But the sustain talk is what our brains kind of glom onto. And then we start talking about that, we get lost. Motivational interviewing says, okay, notice that sustain talk is there and go, it's hard. Validate. And at the same time, you said you want to quit. Get curious. How come? What would be good about quitting? That's motivational interviewing. You're going for the change talk and you're getting curious about what the patient is saying about why they want something different. Three keys to success, or that make motivational interviewing more successful or have the opportunity to help. It's all about the relationship. How the patient feels with you and how you speak and your tone of voice and what you say makes a big difference. We have to learn how to listen, which is easy, right? Except when you have your caseloads and people waiting out the door and your paperwork. It's hard. It's hard to listen. But really, if we're listening to what the patient is saying, this stuff gets a lot easier because they're going to give us what's important to them that we can help them move towards change. And planting a seed. So this is a little different. And some people, this is where there's a bit of a shift in thinking sometimes, is a person might not necessarily walk out of your office and say, yep, I'm going to do that. Okay, doc was right. Let's do this. Maybe sometimes, but often it's us, the healthcare provider, planting a seed of, well, how do you think these two things are related? Or you are drinking more than most of your people your age. Or, you know, your child is having some trouble at school and this might be related to some of the things that he's experienced. What are your thoughts? You're planting a seed. That caregiver might not be able to go, okay, yeah, you're right. Let's absolutely do this. Let's get them in treatment right now. Great if they can. If not, You plant that seed and let them know it's a thing. And then on a follow-up visit, you water the seed a little bit and you ask them more questions about it. This is a part of motivational interviewing that can be helpful so that you don't feel like you have to do it all right in that first visit. Okay, so I'm going to invite you to join me in an exercise. And I'd like for you to think about a secret that you have. And by the way, this is really fun to do it in rooms full of training where people think that they're going to have to tell a secret. So just think of your secret that you have. And think about why you've kept it a secret. Why haven't you told anyone? Now think about what comes up when I say, I'd like for you to share my secret or share your secret. Probably right now, maybe not a lot because you're probably sitting by yourself. But if we were doing this in a big training facility or you were even with a couple other people, how do you think you might feel? If I said, you thought about your secret and now we're going to share it. What comes up? Oftentimes, shame, guilt, people fear of judgment. What are people going to think of me? Lack of trust. They don't know. I don't know you. I'm not going to tell you my secrets. Feel vulnerable. Fear that other people will find out. Fear of having to do something about it now that somebody knows that the secret's out there. And maybe you have some others that came up for you. So now I'd like for us to just go back and think of the secret again. But this time we'll do something different. This time, think about that same secret and try to imagine you have decided that you want to tell someone. You get to pick. You get to pick who it is. And I want to invite you to just imagine that in your mind. You're telling somebody this secret. And what do you want from that person? What do you want them to say? How do you want them to react? What do you want them to do or not do? So you can just spend just a little bit and just kind of picture that scenario. So what would you want? So oftentimes people say they want somebody to listen that doesn't judge them, doesn't tell them what they should do about it, doesn't make it about them. Oh, that happened to me, and you know what I did. They want to be able to trust the person and feel that you're not going to tell anyone. And they want to be understood, and they want empathy. So I've done a million of these trainings. This is a pretty general list of the types of feelings that come up for people. And if we want this, we can assume that most of the patients that we see are going to want and need this too. Because sometimes, isn't that what we're doing? Is saying, well, come on in, tell me your secret. What's going on in your family? What's up? How much you drinking? That could be a lot. There could be a lot of shame there. And so what we do and how we interact and the questions that we ask and how we look and our nonverbal language, all of that makes a difference. And we really want to highlight that listen, no judgment, no advice. You can do this in an MI way and still help them move towards change. Motivational interviewing fits beautifully in with the trauma-informed care principles. Because what we're doing with motivational interviewing is really meeting the person where they're at and trying to understand from their perspective and their values what's going on. We're curious about their lives, their situation, their reasons for a certain behavior, and we're not judging it. We're trying to help them collaboratively through it And so we don't assume that we know better. And that fits in with this patient-cared, collaborative perspective of trauma-informed care. And so again, motivational interviewing fits in very well with a trauma-informed approach. So I wanted to play a video for you that talks about that second key to success of listening. And then we'll play the video and talk a little bit about it afterwards.
It's just, there's all this pressure, you know? And sometimes it feels like it's right up on me and I can just feel it, like literally feel it in my head, and it's relentless. And I don't know if it's gonna stop. I mean, that's the thing that scares me the most, is that I don't know if it's ever gonna stop.
Yeah. Well, you do have a nail in your head.
It is not about the nail.
Are you sure? Because, I mean, I'll bet if we got that out of there...
Stop trying to fix it.
No, I'm not trying to fix it. I'm just pointing out that maybe the nail is causing...
You always do this. You always try to fix things when what I really need is for you to just listen.
Yeah, see, I don't think that is what you need. I think what you need is to get the nail
See,
out.
you're not even listening now.
Okay, fine. I will listen. Fine.
It's just, sometimes it's like, there's this achy, I don't know what it is. And I'm not sleeping very well at all. And all my sweaters are snagged. I mean, all of them.
Yeah, that sounds really hard.
It is. Thank you.
Ow! Oh, come on. Ow. If you would just...
Don't.
Try to see things my way. Do I have to keep on talking till I can go on? We can work it out. We can work it out.
Okay, so maybe some of you have seen that before. It's one of my favorite videos, and I think it's perfect for what we're talking about, because there's so much in there that describes motivational interviewing. So first, for example, she really doesn't want him to fix it. And think about how this might relate to some of the patients that you see, or even somebody in your life that you can see very clearly what the problem is, or what you think the problem is, but the person doesn't quite see it. That's what we're talking about with motivational interviewing. How do we find a different way? She also gives us a lot of change talk. If you caught it, all of her sweaters are snagged. She gets this aching. And that would be an example of change talk where you would get curious about, well, tell me about the aching. And maybe try to tie it to the nail. But she's telling you right at the beginning, it is not about that. Okay, I hear you. It's not about that. Tell me about the aching. What about your sweaters? I know how you love your sweaters. And you're trying to vary with her, in collaboration with her, raise awareness of putting those two together. That's motivational interviewing. Sometimes we can see what the problem is, but our patients and the caregivers, they're not there yet. And so this is an example of us being able to really listen to what they're saying so we can meet them there and help go with them towards the path of change. And like I mentioned before, planting a seed. Maybe they won't walk out of your office with the advice that you want them to do or making that change. But if you can bring it up and they can think about their problem or the situation in a bit of a different way, you're on the right track. So the motivational interviewing skills, there's 4 principles. The first one is to express empathy. And we're doing that all day. Reflect feelings, reflect the situation, let the patient, the caregiver, the person know you understand, you empathize with them. You literally can't really do it too much. The second thing we're trying to do is develop discrepancy. So what are we developing discrepancy between? What the patient says they want and what they keep doing. I really want to be able to lose weight so I can play with my grandkids and be more active. But they haven't made any dietary changes, and they're not taking their medication, and they're not sleeping. Okay, so let's just talk about that. We're not judging it. Let's just develop discrepancy. This is what you want. Why do you want it? How do you think you'd be able to do it? What would that be like if that could be there? Change talk, pulling all of that so they can see, oh yeah, I want something different. Avoiding argumentation. And this can be tough sometimes. Motivational interviewing calls it rolling with resistance. So back to the video for a second, when she says, it is not about the nail, rolling with resistance would be like, okay, so for you, what is it? It's aching, it's the sweaters, it's that. We're saying, I'm not going to get anywhere if I go, yes, it is about the nail. So how can I just avoid the argumentation and take another route? And the fourth principle is supporting self-efficacy. We really need to believe in them so they can believe in themselves. This is a strength-based approach. Motivational interviewing principles believe that the person knows what they need to do in order to change. They might not know exactly how to do it, but they have it within them. So can we help them see that and believe that they can do it? Another activity for you. So you get up, take a stretch break if you need to. And I'd invite you to think about something about yourself that you want to change, need to change, should change. You've been thinking about doing it yet, but you haven't. So maybe something that you're ambivalent about. You can write it down or keep it in your head. And now think about when you have told someone this. So maybe picture it. When you've told someone what you want to work on. What did they do? A friend, a family member. Did they tell you that, oh yeah, you really need to do that? Give you a list of reasons for doing it? Tell you how important it is? Tell you how to do it? Assure you that you can do it? Oh, it's no problem, just do it. Not a big deal. Or pressure you. Yeah, you better hurry up. So just think about that for a second and think about, how did that feel? Sometimes people like this, and more often than not, some people will say, yeah, they were just telling me what to do and I thought of all that stuff already. I don't need the help in that. And so think about how this might impact the work you do with your patients, your clients, your caregivers. Are we telling them how to solve their problems? And maybe, is there another way? Here's the other way. So now try that same problem that you have, and I'd invite you to just answer these questions for yourself. Because these are motivational interviewing questions in terms of, they're not magic questions, they're just open questions that are asking people to think about different levels of change. So first, for example, why do you want to make this change? How might you go about it in order to succeed? What are the 3 best reasons for you to make the change? And how important is it for you to make the change, and why? And so now if you think back to the darn cat, this is darn. Why do you want to make the change? Desire. How might you do it? Ability. What are the 3 best reasons? And how important is it for you to make the change, and why? Need. So it's just, even if you can ask one in the limited time that you have in the visit, these are the types of questions that get the person to start thinking about their problem, situation, behavior change in a bit of a different way. So I'd invite you to take about 5 minutes or so and really answer these questions for yourself. And if you can, sort of see what that's like. See how these answers feel differently than when someone kind of tells you what to do or what you should do. So that telling people what to do is called telling people what to do. And it's also called the writing reflex in motivational interviewing. And that's just the urge to tell people what to do, especially, and it happens all the time, and we might do it in a very kind, nice way, not necessarily like a you should be doing this way, but a nice sort of like, oh, yeah, you really should stay out of jail because your kids are, it's important that you're with your kids. Or, yeah, if you stopped smoking so much weed, life would be a lot easier for you. But we're still telling people what to do. And that is not motivational interviewing. Guess what? This is hard. And when we do these exercises, people say, oh, this is hard. I want to tell people what to do. Yeah, because we're human and we're trying to help. This writing reflex is also made stronger when we're pressed for time, which is probably everyone. And when you feel like, okay, I gotta let them know what they can do so I can write it in the note and get on with it. And when the patient's engaged in a dangerous behavior. So when they're doing something like that, let's say their diabetes is uncontrolled, or they're recently started drug use or something like that. Is it dangerous? Absolutely. Do they need us to literally tell them what to do and not use motivational interviewing? No. Because they know what to do. Can we ask an open question and say, well, what are your thoughts about this new drug use? Or how have you been feeling now with your levels off like that? What would make it better? How could we make it better? That's that collaboration, and how it's just with some open questions says, well, what do we do about this problem? Now, if you have to tell people what to do, here's the recipe. Do it in a motivational interviewing format called ask, tell, ask. You can think about it as a little sandwich. It's like a feedback sandwich. First, so let's say, let me set this up. Let's say a patient comes in and they have an ACEs score of 3. And you want to tie this to some of the health problems they have. They have been a smoker for years, they have COPD, they have high cholesterol, and you're trying to tie it to maybe getting some treatment around some of the trauma in their past. So first we want to do ask, what does the patient know about whatever you're talking about? So in this case, what do you know about how some of the difficulties that you've had when you were a child can be related to your health and some of the health problems that you experience now? What do you know about how those are related? Because what I'm going to do is I'm going to tell in a second, but before I just start telling, I want to ask the patient, well, what do you know about it? Because that really enhances the collaboration. And I really want to know, what do they know about it? Because that might be a jumping off point. And then I'm going to tell in a neutral, non-judgmental manner, well, what we know is when things happen when you're young and life was difficult, or there were some adverse experiences that you had to go through, that can really change the way your brain works sometimes and impact your health as you grow. And I wonder if in part that might be what's happening. Then we ask them, what do you think? So that's where the feedback sandwich comes in, the ask, tell, ask. You ask, what do you know about? Then you're going to tell, you're going to give your advice or make a connection. And then you're going to ask again, what are your thoughts? This is a really nice recipe for it to be collaborative and also get that psychoeducation or that piece of what you really want the patient to know. And in that tell part, if you can keep it to 1 or 2 pieces of information, the better. It's short and sweet, what you really want them to know, and straightforward. Because if we keep talking a lot, then it can get lost. So this is the ask, tell, ask. And you will learn more about it, and you'll see these slides in some follow-up trainings on motivational interviewing, where they go into more detail about the ask, tell, ask within the framework of the ACEs screen. Another reminder, not that I love cats, but I do love change talk. And that's the whole point with motivational interviewing. The darn cat, the desire, ability, reason, need. We're just getting really curious when we hear change talk. That's how you do motivational interviewing. Now I'm going to switch a little bit and talk about the core skills of motivational interviewing. You know why we do it, you know why it's important with the change talk. And now let's talk about how do you actually elicit change talk from the patients. First is asking open-ended questions as opposed to closed-ended. We'll talk about that in a second. Reflect and respond. Use the ask, tell, ask. That's the little kid with the sandwich. Affirm any step in the right direction. So even if it's not exactly what you want, being able to give affirmations of, hey, you came into treatment, you looked up some of the meetings, you're trying your best. Validate the patient. Really, validation is so important and people need a lot of it. And so do we. There's nothing wrong with it. And then summarizing the change talk. You do this already, but summarizing back what you've heard, what you've talked about, and that can help move a patient on. So for open-ended questions, when you're using motivational interviewing and you want to get curious to elicit change talk from the patient, you want to ask questions that are open-ended. So they usually start with what, how, why, describe, or tell me. So for example, closed-ended questions to open-ended questions. Closed-ended, you can only answer yes or no. And the open-ended questions goes beyond that. And I don't know if you've ever thought about open versus closed-ended questions, but I think about this stuff way too much. And open questions, they allow the patient to really answer how they want. When we ask a closed-ended question, we're actually assuming that we already know the answer. For example, do you want to quit smoking? I'm assuming as a healthcare provider that my patient's going to say, well, yes, I do, but maybe they don't. And so instead, can I ask an open-ended question, like I'm down the fourth one there, what are your thoughts about quitting smoking? That's a different question. Do you want to stop? Yes or no? The right answer is yes when you're talking with your physician, but that might not be at all what's true. So what's the point? What are your thoughts about quitting smoking? Maybe there we'll get into the weeds about the ambivalence about, oh, I want to stop, but I can't. And then we have lots of change talk and lots of places to start with doing some MI. So you can just see there, do you agree? What do you think? Did you understand? What did you understand? Do you have any questions? What questions do you have? And I just want to say, I know that for a lot of the physicians that are watching this, I know these are hard. And I know that a lot of times you don't want to ask open questions because you don't want more of that information. And in every case, maybe that's not what's needed. But when you're trying to get at a person who doesn't really want to do something and you're trying to get him to do it, open-ended questions are important because we really want to understand it from their perspective. Don't you want to get your child some help? In what ways can you help your child? Do you have any concerns about your health? What concerns do you have about? You can see how the open questions just makes it more broad and actually puts the onus on that patient to answer what's true for them. So open questions is a big, big part of motivational interviewing. The next big part is making reflections, and that's really reflecting back what you hear. And motivational interviewing takes it a step further than just sort of basic reflections, and they invite you to take your best guess as to what the patient might mean. So for example, there's three main types of reflections in motivational interviewing. The simple one is just really repeating back what the person says. Complex is you repeat back what you think they mean. So you might add some how do they feel to it? Or what do you think is really kind of underneath what they say? And double-sided is you're exploring both sides of that ambivalence. And you're really kind of saying you want this and you also want this, and you're offering it back to them so they can respond and talk about it. Here's an example. The patient says, I know my child needs help. I'm just not sure about all this stuff you want me to do. A simple reflection would be, you know your child needs help. That's good. When in doubt, reflect. Simple reflection, good. Because then you're getting that person to talk about what they just said. That's change talk. I know my child needs help. Simply reflect it back. Now the complex reflection adds a little bit more. All this information seems overwhelming and you're not sure what to do. I added a little feeling there. You're not sure, the overwhelming, you're not sure. I'm inviting them to talk about it. Now, the other part with reflections is they are not questions. So you notice there's a period at the end. You're not saying all this information is overwhelming and you're not sure what to do. My eyebrows go up, I lean in forward, my voice goes up at the end. A reflection is a statement. Otherwise, you turn it into a close-ended question where they answer yes or no. So all this information seems overwhelming. You're not sure what to do. I'm sort of saying that for them so that they can then respond to that. Is it true for me? Is it not true for me? I don't know. It's kind of it. That's what we want, because then they're talking more. They're searching more about what might be going on. And the double-sided reflection is that both sides of the ambivalence. You're not sure about the recommendations, and at the same time, you know your child needs help. Now, the double-sided is when you hear they feel two ways about things. And if you can, you want to start with the part that they're not sure about and end on the change talk. So for example, you're not sure about the recommendations. They're saying, I don't know about that. At the same time, you know your child needs help. That's what I want them to talk about. You know, yeah, because he's been so sad lately and he hasn't really been able to sleep and he's got that. That's all change talk that we can then use to, oh, well, how do you think we might be able to help him? What do you know about how we can treat some of those symptoms? If I switched it and say, well, you know your child needs help, but you're just not sure about these recommendations, I'm kind of then inviting them to talk about that. And that's sustained talk. Yeah, I can't get to these appointments. I really don't know what you're asking. The last doctor we saw, I don't know about that. It's too far for me to drive. All of that might be valid, but not helping us to get the patient to talk about and become more motivated about getting the child some help. So reflections, simple, complex, double-sided. And they're not questions, they're statements. So your voice just stays even at the end. Now, how do these fit into the ACE screen? Sometimes, so these are ACE-associated health conditions, which I know you know and I know you've seen before. And how does it fit into motivational interviewing? Sometimes, or often maybe, your patient or the child may come in with any one or any number of these. It might be aggression or fighting, or anxiety or depression, or COPD, obesity, anything that we can see. So we're thinking, okay, well, if they're coming in for, let's say, depression, do they know how it's tied to their adverse events when they were a kid? Do they know that there's a relation to that trauma? Maybe I can help raise awareness about that. And you can get curious about the depression and how does it fit into ACEs and other things that they may be experiencing. The evidence, and then also the evidence-based stress strategies for reducing for mitigating toxic stress. So these are great, awesome things that we know work to help protect against toxic stress and help treat it once it's already there. Guess what? Not everybody is super motivated to do those things that are on there. So you might find that you're using motivational interviewing techniques to get people to Look at these. Experiencing nature. What would it be like to go out for a walk? What are your thoughts about mindfulness? What do you know about mindfulness? Tell them a little bit about it, about what it is. What do you think? That's the ask, tell, ask. So we know these work. Sometimes we have to use motivational interviewing to put this on the map of how would somebody fit it into their life? Do they know about it? So now some practice. You know open questions, you know reflections. Those are two really important parts of motivational interviewing. And now we have some time to practice. So I'm going to read these to you and then encourage you to come up with some complex reflections and open questions for these scenarios. So the first one, a teen patient with an ACE score of 3 is continually in trouble for fighting and missing school. And he's in the pre-contemplation stage. So remember, that means he's not really even thinking about making a change. This is just how life is, and why are you talking to me about it? This is just how I go. Second scenario, your patient's a child with an ACE score of 5, and you want to discuss the importance of treatment for toxic stress with the caregiver. The caregiver knows that the child needs help, but is apprehensive of the system. The caregiver is in the contemplation stage. So contemplation, remember, is there's some ambivalence. That the caregiver, let's call her, she knows that the child needs help, but isn't quite sure what to do, and we don't know yet how that's going to work. Different scenarios, and you can think about what are some open questions and what are some reflections. So to help get you started, for the first one, where do I start? Really ask yourself, what's my goal with this patient? And this one, you could go different ways. What are you going to address with MI? You could raise awareness about the ACE score and how this could affect the patient's behavior and health. Or you could raise awareness about fighting and missing school and how this impacts health and future health. See where the child is with that. There's no right or wrong. It's really kind of where you want to go with it, but you want to know. And with the second one, where do you start? Again, what's my goal with this patient? Where should I start? Maybe on this one, you really want to understand and validate the apprehension and help that patient move towards action. Well, she has to be understood first. And then maybe raise awareness about how treatment can help and help the child to feel better. So that's a place to start. I invite you to take about, 5 minutes or so, if it takes that long, and just think about 4 or 5 maybe open questions and 4 or 5 reflections for each of these scenarios to just kind of get your mind thinking about the difference between the two and how that might be different than a closed question or what you might have done in the past. Okay, welcome back. So the first one, the teen patient with the ACE score of 3, who's always in trouble at school and for fighting and missing school, who's in the pre-contemplation stage. So you ask yourself, where do I start? Depending on where you started, these questions might be different. But here are some open questions. What do you know about the link between the difficult experiences you've had and getting in fights and missing school? I have no idea what the teen's going to say, but I'm curious. And I want, by asking this question, to highlight to the patient, to the teen, there's a connection. What do you know about it? And then you can use ask, tell, ask to give a little bit of information. The next one, what ideas do you have about what you want to do when you're older? What do you like? Now that might seem like it's not even related to anything at all of what you're doing or the ACE score or anything like that. But I would argue that getting to know the kid, even in the 15 minutes that you might have with them, finding out and planting that seed of, well, what do you want to do when you're older? What do you like? Gets them thinking about how that might be tied to staying in school or not fighting. What would the benefit be if you stopped fighting so much? There, I'm just asking for a reason, a benefit to not fighting. Is there one? Can you think of it? Another one for the action stage of change talk would be, if you wanted to stop fighting, how do you think you would do that? I literally don't know what he would say, but I'm trying to join with him and say, what would that be like? Because that's going to get him thinking about it in a bit of a different way. And that's where the change can happen. So those are open questions. Now, for the reflections, remember they're statements. You've had a lot of strong feelings and you don't know how else to manage them. So with this, I'm trying to get at, what's he really feeling? You know, with the questions, they're bringing out more, he's talking more. The reflections sometimes go right more quickly to emotions. And I'm just kind of putting it out there. You have these strong feelings and you don't know what else to do. Yeah, I never learned. My parents fight all the time. I don't know. So usually you'll get some more information that you can then get curious about. Another reflection. It's really hard to trust anyone with what you've been through. There, I'm acknowledging the adverse childhood experiences without really even saying it and saying, I get it. It's hard to trust anyone. And in doing this, I'm really offering them to talk about, is that true for them? Is it not? Believe me, if you make a reflection that's not quite accurate, the patient's going to let you know. And usually they're not mad about it. They'll say, you know what? It's not that I don't trust anyone. It's just that, why bother? Or, you know, it's not worth it. But even if you're a little off, it's okay, because you're trying to understand how they feel, and that feels good. Another example, maybe you'd like to find some ways to feel better and more in control of what happens to your body. I don't know. They might say, nope, I really don't. But more often than not, maybe if they say nothing, I'm still planting a seed and letting them know there are some ways to feel more in control, because I bet when you're fighting, it doesn't feel great. Even if they don't want to admit it in the room, that's fine. You're planting the seed so that they can think about it. And then you can follow up with, what do you know about some of the things that you can do when you're angry like that? Or when somebody says something insulting like that? Besides, what do you know? Open questions, reflections. Now, for the second one, some open questions. Tell me your concerns about treatment. We might want to know, what are they worried about? What are some of the concerns? What do you know about how treatment can help your child to feel better? Or maybe even, what do you know about what treatment is? You know, you're always deciding when you're working with that patient or caregiver, what's the best question to ask? Do they even know what treatment is? Is it counseling? Maybe that's where we start, because they don't know what it is. What are your thoughts about having an initial meeting with the counselor? I'm not saying I'm going to set this up for you. It's not directive, but I'm actually leading them towards, well, what are your thoughts about this? Because if there's apprehension there, maybe we can talk about that. What is most important to you right now regarding your child's health and well-being? That's a great question, because you're getting from them what's important, and then you can get curious about how do we help that? What do you know about how we help that? What do you know about what we can do here? Just getting them to think about it in a different way. Now, the reflections, the statements, you really want your child to feel better. That's one that you can probably use most of the time, and just leave it there. I know that's hard. You really want your child to feel better, period. Stop. Because the person will say, yeah, I really do. I'm worried about them often. You're concerned about what responsibility you have if your child gets treatment. Now you're kind of pulling, like, what else is going on there? What might come up for them if the child gets treatment? That's definitely something to be talked about if that's what's keeping them out of treatment. You would like for things to be better at home. You don't trust the system, but you want your child to get help. There's that double-sided reflection. You don't trust the system, that first one, sustain, but you want your child to get help. That's what you're offering them to talk about. You really want to see your child laugh and play like they used to. Maybe that you think, what does that have to do with it? But that's what's not happening now. And that's what the caregiver or the teen wants. You want to feel better. How do we do that? So the next part is affirm and validate. You know about validating, that's the empathy, that reflection back. And affirming is their strengths, their efforts. Are they doing something that's towards taking a step towards the behavior change? So some examples. You made it to the initial appointment. You really want to get help for your child. You're acknowledging what they've done and the steps they've taken. You keep trying. You want to feel better. I think this comes up a lot with, I had a patient say to me the other day, I've been at 30 days, he has alcohol dependence. I've been at 30 days for so many times. And you could sit there, was just there, but you keep trying. You really want to feel better. You're able to cut down by a few cigarettes. How did you do it? With affirmations, you can get curious about how did they do it. They're talking about what they did. That's that ability change talk. Then they hear themselves talk about it and they go, well, yeah, I did do that. Validate their concerns. So this, maybe the person isn't going to change. They're still not sure right at the beginning. You're validating that their concerns are important. The health of your children is important to you. You want to be the best mother that you can be for your child. Even if the person isn't ready to make a change, hearing that they want what's best for their child helps the relationship and helps them to trust you to then be able to hear what you're trying, the message that you're trying to help them with. And then the last part is summaries or summarizing the change talk. You probably do this already, but it can really be helpful for sort of that transition from, okay, we talked about how you're feeling about coming in, and now let's just kind of put our toe in the water and see, can we actually schedule something or actually kind of push towards that more action stage instead of just thinking about it. Sometimes you won't be able to get there right away, but there's not a harm in asking in a MI way to see where they are. So for example, we talked better so you don't have to fight so much. You don't want to do therapy, but you're open to learning some ways to manage your anger. We can set up initial appointment with you. We can set you up with an initial appointment next week. Now I don't say, what do you think? It's just a statement there. We can set it up. I'm offering. I'm pushing a little bit, but I want him to get an appointment and we talked about this stuff. So I'm just going to leave it there and see what he says. You mentioned that your child has been sad a lot and you want them to feel better. We discussed a referral to treatment to help them learn some coping skills. We have some appointments next week if that works for you. It's a nice, non-directive way to guide them towards, let's see. Now, some people might say, no, I'm not ready. Okay, ask a question. Okay, what do you think might make it more likely for you to be ready or to schedule the appointment? That's another open question that's just curious about what might make it easier for you. And the last one, you're concerned that your child has an ACE score of 4. We discussed some ways to promote the supportive and protective factors that already exist. I was thinking we could make an appointment in about 2 weeks to see how things are going and see if you need any further support. Summarizing, sounds like the plan is keep doing what you're doing. Here's some more protective, supportive factors that you can do. Let's check in 2 weeks. That collaborative style. So one of the last points to make today around motivational interviewing is, where does resistance start? And this works better when I'm with a group and I ask somebody to come up and I put my hand up. And this was all before Corona too, but when people would touch my hand with no problem, and put my hand up and I just sort of start pushing. And most of the time people start pushing back, and then I push a little bit more, and then they push me back. So what does that mean? It means that resistance takes two people. And so often, if we find that our patient is pushing back, it's probably because maybe we have been a little too pushy at the beginning. Maybe we're telling them what to do. Maybe we're giving them advice. And how you know if the patient is starting to resist or if we're maybe being too pushy is they say things like, yeah, but I can't do that because, or, well, I tried that and, or, sure, okay, yeah, and they can't wait to get out of there. All of those are yellow flags that there's some resistance. And as soon as you notice it, it's just take a look at yourself and go, okay, maybe I'm a little too pushy there. How do I go back and maybe ask an open question or sort of see where they are with this so that we can be more collaborative and work together towards the goal. So just a reminder, we've covered all of this. You can read it, the do's, the do nots. And of course, always adapt your communication to your setting. You know your patient better than me, better than motivational interviewing. You can be sensitive to who they are, where they're from, and what's important to them. And the best way to learn these strategies is just to pick one and practice it for a little while. See how it goes, because it takes a little while for it to change in your brain. So if you practice open-ended questions one day, and then bounce it off with a coworker, or just sort of think about it, then try some reflections the next day, and that's kind of how you can work it in. Good luck, and thank you.
Thank you so much for a great presentation. We're so glad you took the time to review motivational interviewing with us. We'll go ahead and transition to our questions and answers now. If you have any questions for us, please feel free to raise your hand and we'll unmute you, or to enter it into the chat box. Okay, and I think we have some previous questions that were submitted that we can go ahead and review as well. All right, Dr. Joy, so tell us, how can motivational interviewing be effective when a person might not be ready to contemplate making changes? How do we avoid unintentionally blaming or becoming confrontational with someone?
You want me to answer that now? Okay, so the first one was, how do we start where somebody might not be ready?
Yeah, exactly. And then, sometimes I think it's easy to unintentionally blame or become confrontational with someone who's in a pre-contemplative stage. So if you can talk about that a little bit.
Sure. It's really helpful to understand where the patient or the person is
and realize that our job is to meet them there and help walk with them towards change. It's not to come in and solve it or tell them what to do. If you think about the nail video, it's not about the nail video. I love that for that reason. She's not ready to get rid of the nail. It's not happening. And so if he tries to push her, that's what we see a lot in our patients. You need to do this. You need to do this. Well, they might not be ready. So it's our job to understand what would make you more ready. And that's where you can really focus on those being curious around change and what might be there to motivate them. And I think if you lead with, okay, it's my job to be curious and help guide them towards change, it helps you stay out of judgment, because then you don't feel like, oh, I have to make them change right now. We can't do that. All we can do is sort of help them along the way.
Thank you for that. Yeah, curiosity seems to be really the key here in terms of avoiding that judgment. And we have a question that came in from Lisa. How can you help the patient make the connection of what happened in their childhood, their ACEs score, and any current health disparities they may have?
Mm-hmm. Yeah, good question. I think by same thing, seeing what they come in with. And like, for example, and Lisa, if you have a specific example you're thinking, I'd be happy to hear it. But if they come in with depression, or they're not sleeping, and maybe they're not aware of ACEs, or they don't talk, they haven't connected the trauma, any of that, it's just sort of think about them. Are they in pre-contemplation? They don't even know it's a thing. It's our job to raise awareness. So what do you know about how some of the things that you've been through when you were a child can affect your health currently now? And that's just that open question to kind of, if you think about the ask, tell, ask, what do you know about it? And then you can tell them a little bit. You know, these things are connected. You can tell them about the study, or put it towards the website and say, this is some of the things that I think might be going on. And then the last part, the ask, what are your thoughts? And that's a way to just open the conversation. And it helps if you do it with something that they're coming in with.
Thank you for that. And Lisa adds, yes, obesity, weight management, diabetes, these are difficult topics for people sometimes to contemplate changes.
Definitely. And I think too, that the health conditions like diabetes and obesity aren't necessarily automatically linked to the stuff that happened to me when I was a kid. We think about that as more of like depression or anxiety or PTSD and that sometimes. And so just using that ask, tell, ask of like, what do you know about how these are connected can open that door, and then you can tell them a little bit about it and just plant the seed.
That's great. Yeah. And I like that point about not assuming that things are necessarily related, but really relying on the person to tell us what they think the connection might be.
Mm-hmm.
Okay. And we have one other question that was previously submitted as well. Providers and patients don't always agree on the need to make a change. How can motivational be helpful for someone in this situation? And there's an example. So for instance, a 73-year-old man who says he's not worried about counting carbohydrates to manage his blood sugar, even though he's been to the emergency room several times in the last year.
Mm-hmm. I think the same thing, the same answers for Lisa's question. It's really taking what that person is coming in with and trying to help them realize that there's more to it. So I forget exactly what you said with the example. He's not managing his carbohydrates, but he's been in the hospital.
Right.
Is that what it was? Yeah. So I get curious, like what's been putting you in the hospital? What do you know about how not managing your sugars and being in the hospital are related? And you're not sort of trying to set him up like, haha, I'm going to tell you, of course, but you're just opening that question because maybe he doesn't know, or maybe he does, but he doesn't want to talk about it. And it gives them that sort of like, okay, they're kind of listening a little bit more. Awesome. And then you can use all the skills that to help lead them that way.
That's great. Yeah. Thank you so much. I think we've had some great questions here and some great insight into curiosity and how to approach a situation where someone might not be in a very active readiness for change mode. Please go ahead and stay on, participants, just for a minute. And we want to thank you for everything that you've contributed today for our lecture and also for our questions. And hope that this is something that is very helpful for bringing into your lives.
Great. Thank you. Good luck to everyone. Thanks for listening.
Thank you again for watching this lecture. Remember to complete the registration and evaluation. We will contact you soon if you are one of our raffle winners, so stay tuned.
Make sure to follow us on all our social media accounts and subscribe on our webpage for more information of our 12 lecture series, ACEs Aware Ventura County, and all things ACEs Aware.
Thank you for joining us on our mission to bring better help,
Better health.
and better hope to Ventura County and beyond.
Bye. See you at our next session.
Thank you all again for joining us this evening. These are our final reminders, so please make sure that for those of you who have joined us, both live and the recording, complete the evaluation. And tomorrow we will be announcing our drawing winner for this session. And stay tuned for our session next week, which is session 2 of Unit 2 on increasing motivation and decreasing perceived barriers. And again, thank you so much to our speaker, Dr. Chudzynski, and our moderator, Lucy. Have a good night, everyone. Bye.